Find out the 2 critical steps for managing acute organ injury and severe hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 50-year-old woman with chronic kidney disease is brought to the emergency department for severe headache, vomiting, and rapidly worsening confusion. Her history includes Budd-Chiari syndrome, rheumatic mitral stenosis, early-onset Alzheimer's disease, preeclampsia 18 years ago, and obstructive sleep apnea. She has never smoked. Her medications are warfarin, lisinopril 20 mg daily, furosemide 40 mg daily, metoprolol succinate 50 mg daily, and donepezil 10 mg nightly. Pet dander causes watery eyes, egg exposure causes a skin reaction, and quinolones cause joint pain. She uses continuous positive airway pressure at night. Her husband reports that she missed her blood pressure medicines for 2 days because of vomiting. A previous brain positron emission tomography scan showed a pattern consistent with Alzheimer's disease. Her pulse is 104 per minute, temperature is 36.8 degrees Celsius, respiratory rate is 19 per minute, blood pressure is 224 over 126 millimeters of mercury, and oxygen saturation is 94% on room air. She is agitated and disoriented but moves all extremities. Fundoscopy shows optic-disc swelling and retinal hemorrhages. A low-pitched diastolic murmur is heard at the apex. Computed tomography of the head shows no intracranial hemorrhage. Estimated glomerular filtration rate is 26 milliliters per minute per 1.73 square meters. Normal, at least 60 milliliters per minute per 1.73 square meters. Potassium is 4.9 milliequivalents per liter, normal 3.5 to 5.0 milliequivalents per liter, and urine albumin to creatinine ratio is 940 milligrams per gram, normal less than 30 milligrams per gram. Which action has the highest immediate priority? Option A. Admit her to intensive care. Start intravenous nicardipine at 5 milligrams per hour with continuous monitoring and lower mean arterial pressure by about 50% during the first hour. Option B. Admit her to intensive care. Start intravenous nicardipine at 5 milligrams per hour with continuous monitoring and lower mean arterial pressure by no more than about 25% initially. Option C. Withhold antihypertensive treatment until magnetic resonance imaging of the brain is completed to assess for posterior reversible encephalopathy syndrome. Option D. Give oral amlodipine 10 milligrams and lisinopril 20 milligrams immediately and lower the blood pressure to a normal value within the first hour. The correct answer is option B. Admit her to intensive care. Start intravenous nicardipine at 5 milligrams per hour with continuous monitoring and lower mean arterial pressure by no more than about 25% initially. Severe hypertension with rapidly worsening confusion, vomiting, optic-disc swelling, and retinal hemorrhages represents hypertensive emergency with cerebral and retinal target organ injury. The absence of intracranial hemorrhage does not make the condition less urgent. She requires intensive care admission, continuous monitoring, and a titratable intravenous medication such as nicardipine. The initial goal is to reduce mean arterial pressure by no more than approximately 25% during the first hour, unless a separate condition requiring a different target is present. At 224 over 126 millimeters of mercury, the verified mean arterial pressure is 158.7 millimeters of mercury, making an initial 25% reduction target approximately 109.0 millimeters of mercury. Reducing mean arterial pressure by 50% in the first hour would risk cerebral, myocardial, and renal ischemia because chronic hypertension shifts autoregulation toward higher pressures. Oral amlodipine and lisinopril are too slow and insufficiently titratable for hypertensive encephalopathy, and immediate normalization would be dangerous. Magnetic resonance imaging may later demonstrate posterior reversible encephalopathy syndrome, but treatment must not be withheld while awaiting imaging. In summary, the highest priority is controlled intravenous pressure reduction in an intensive care setting. The objective is not immediate normalization, but reversal of ongoing target organ injury without causing hypoperfusion. Nicardipine permits close titration toward the recommended initial reduction. Primary teaching point: hypertensive emergency is defined by acute target organ injury, not by the blood pressure value alone. Secondary teaching point: the initial reduction is generally limited to approximately 25% of mean arterial pressure during the first hour, followed by more gradual reduction if the patient remains stable. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.
Endless Medical AI is the medical chat where 3 AIs cross-check every answer. EndlessMedical.AI